and all 5 improved with manipulation. There was one person who it was decreased over 50%, and they did well here. So of the 14 patients, more than half didn't improve on CAT scan, but of those 14, 13 did well with the manipulation. The protocol that they used was to manipulate every day for 3 weeks. One manipulation, as far as I can recall. Yep. No, it wasn't only one manipulation, because part of this was immobilizing. That was part of the protocol to do it. But once they could get to the barrier, it was done, and presumably that was it then. There was no description of corsets, no description of anything other than this was just done.
No exercise?
Don't think so. Because what they were trying to prove, and they went back and compared it with a review that had been done by a fellow, Vince Nugar, who was a student of mine when I was in the army in Britain. And this guy went on and took his PhD and has written copiously, so I suppose I influenced his career a little bit, although I wasn't sure that I'd done so at the time. But I read his article, I must say, on the looking at a rotary manipulation as related to orthodox conventional physical therapy, showing that the manipulation was somewhat better. But it was a fairly crude procedure in terms of what we would do, even then, but certainly now. You know, it's basically kind of leg over, shoulder back, and wacko. And I don't know where he picked up his skill for manipulation anyway. So, this is an interesting little group of stuff about perhaps we've been a little overcautious. But we've got our protocol, and we've got our business about the straight leg raising and the neurology and all this kind of stuff. And we've eliminated that group. And then we would go into perhaps a slight stress mobilization to see whether there's any leg pain. We've eliminated that group. And so now we're into a fairly safe group, knowing that we're not going to do a major rotational stress. That's what we're going to do right now. Okay, Chris, come and let me sweat a little.
Facets are impacting, that is not enough to damage the disc?
No, I don't think so. I think it's enough to protect the disc, probably. And it's enough to sort of perhaps, do we consider that that contact point opens this out more, you know, putting it through to that fixed point, and thinking that puts a bit more strain on the disc? It seems that it doesn't. Not one of them were made worse. Not one of the prolapses were made worse. But of course, they had the protocol that we're going on in terms of, you know, looking for those discs with frank neurological signs. These were people without frank neurological signs, but did show a CAT scan or a problem on disc, because it's more a symptom picture than a sign picture. And we wouldn't do it for people with signs of neurological deficit. Although, to do a distractive maneuver would probably be perfectly okay. If you've got them on traction and nothing's happening and it doesn't seem as if it can open that segment. Perhaps there's a block at that segment as well, and perhaps that's stopping the traction moving into the disc. I mean, this is all speculative, of course, who knows? And those are the ones that we might do a little distractive release on. Probably not as hard on that segment, because it doesn't allow the creep as is traction itself. Okay, so we've got exactly the same as we did this morning. Exactly the same. We need to look at the patient in terms of our position here. You see how important it is for all of you to have tables that go up and down. At least one table that's available. The trouble is, if you get one, you can't stand it when it's not in the room that you're working in. So you have to go and get another one, and then you decide, this is an investment I'm going to make. And then you find one or two of the models you don't like. Okay, so here we go. And then you kind of take them to an engineering shop and have a few little modifications placed on them. All right, so try and find a joint that is normal or stiff. And what we'd like to try and do is to come from the bottom, so it's going to be a little difficult if we've got some hypermobility like we have in Ralph's case, because this technique we'd have to be doing it with the upper lever, and I haven't taught you that yet, so we'll just have to kind of set it up and simulate it a little bit. Okay. So I'm going to use exactly the same procedure. I'm going to work up to the joint, ease off. Then I'm going to come down and have some fabric certainly on the table so that the patient will move around, so we don't want them slipping. And then I'll come around here. And Chris is giving me a little tiny bit of spasm here. Have you got any pain there?
No.
Yeah, just wanting to keep me on my toes, obviously. Okay, so now I will come around to this joint here. I'm looking at this joint that's in its neutral position, and I'm just very gently going to take it to its barrier, okay, which I've now got at its barrier. Now, my technique is going to be to pull in the oblique line more that we know these joints work at. So if we've got the axis here, I'm coming at kind of right angles to that axis, not straight across like that. That will be the modification we'll do for the L5-S1. So I'm coming up a little bit and I'm coming down and across, almost through the femur there. And it would be very nice if I could push on Chris here, push this down and pull up with my fingers, but I know that I would never move him like that with this hand. I need more power, and I've got to get this into that position by using my forearm. I can monitor this perfectly well by doing what I'm doing now. If I could do this, very nice, but I can't do that, and that will compromise my technique. So I'm going to come into the barrier, ask Chris to just breathe gently out, not breathe in particularly, just out, so it's no big deal. Just take up the slack and just feel that happening. Now you can see where my body is. It's very close to Chris, so that when I pull, he's pulled into my body. I'm not at a distance like this so that there's all this space. I'm going to just pull it into me, so there's very little distance of rotation that he can do. So I just take up the slack a few times, just sort of into that, just sort of sense it. Just breathe out gently and just into the movement there, and I can't move him. This is having Mexican. If I had if it had raw meat, I'd have been all right. Okay, so if we got to come into and just into that position and then push down that. But that is the movement, and this is my position here. Okay, I'm just pulling across and down there. So this vegetarian stuff, it doesn't give you that energy necessary for this strong stuff. All right? So that is exactly the same as we did this morning, except there we did this. Now it's the same setup. We just gently go through the barrier, then across that joint at an oblique angle, which is generally through the knee, and just push down like that. And your body there, and it gives you a lot of confidence that you're not going to move him very far. All right, let's see how we do with a manipulation of the facets. And I'll show you a little modification I would do with a guy of Chris's size in a few moments, and see if I can move it in a little different way.
When you're mobilizing and you're checking to see
Or that whatever lock we're using, and we're at the moment using the flexion lock, but whatever lock we're using is sort of as efficient as it can be. So it's quite a good idea to have a small sandbag or a roll of towel that we can get to a kind of critical height here. And if I were doing, let's say, the L2, L3, I would place this no higher than about L3, 4 there. And that will give me a little bit more of a side bend lock. So it will maximize the side bending elements. And then I'm going to do the rotational elements. If you can just put your leg down a second. Then bend this one up. So we mustn't have this one, as you often see in many pictures, underneath the joint being manipulated to increase the side bend there. This joint should be in its neutral position. This side bend should be lower, involved with the lever. So now with Bill, I can kind of come round at a higher level. And we'll try a few modifications as we go around the class and see where we go with these. Okay, so with Bill, I'm going to come into this, and I would choose to use this technique as it stands now, all else being equal, without putting any more increase of leverage. Now, it's pretty obvious to me that I'm not going to be able to move him with the standard 4-point technique. So I'm going to get my forearm, right across the transverse process, in fact, of L2, L3. So that's on L3, and I'm as close as I can. I'm coming in line with my body to give myself a little bit of a pull, and my pull will be down, or my jerk will be down and through his hip again, but I'm keeping my body close by so he's not feeling insecure. I don't think we should be standing here and doing this. That's very bad in my estimation. We should be very close. So, can you just breathe out? And you follow him down, and I just move him into that movement there, okay? Nothing happens. So, I go and have a coffee and leave him on a hot pack for a while to loosen him up a little. So then I come back, having had my Wheaties and everything, and into a position here, and I think, can I increase the leverage? Now, I'm going to show you an increase of this leverage because I don't want you to read it in a book and try it and do it wrongly, because it can be quite, I think, stressful if you do it wrongly. I'm going to try and increase the weight that I'm applying to his whole upper side here, including this leg, so that I can go more towards the barrier just by weight. And I have to do this by putting my leg on his. Now, under no circumstances does this become the lever. It's merely that I'm taking up a little bit more of the slack and into the barrier by this weight. I then must ignore my leg. It's not that I'm going to be sort of have my leg up and whap down with my leg. So I come into this position. That's my technique position. Now with Bill, I'm going to come up and just place my leg on here like that, and that will be the maximum that I will do with my leg, which is just to take up the slack. So I go back there. Okay, well, can you just breathe out gently? And into that position there. And this does not enter into the leverage system. It's merely pulling like this on this joint here, and then I increase that little impulse only with my arm. It's not that you do that. You can imagine this lever placed through the disc, all that Cassidy's spoken about, might in actual fact now be refuted if you're using that length of lever through your leg. That would be enormous torque that you would place on that joint. So it's merely a good way of getting to the end of the range. And on people that's Bill's size, or my size, I would do that very, very frequently, because it saves you a certain amount of strength. So let's try the increase of the side bend, and let's try the use of the leg, but not as a lever, merely as a way of exploring a little bit more into the barrier. So you're all going to have to wear culottes and things at work.
Where do you put your leg?
Just lay it on there like that. And I still keep close in. So, and I'm leaning into his body actually, so that there's not very much chance that I pull down on my leg. All of you. Is it strictly necessary, if we had this kind of scenario where we're wondering about a disc? Certainly Cassidy, because I don't think that he's taken the types of technique to a level of consideration that perhaps we have. I mean, that sounds a bit arrogant, but looking at the article, it's still, still fairly basic technique. If we were doing a distractive technique, perhaps it's not all that necessary to put the spine into all of this locking if you're a little bit worried. Perhaps it's good to just keep the spine in its actual resting position to do this distraction. So I think that if we have a sort of saw joint, rather than put any risk of kind of rotating a little bit too much or anything like this, it'd be a good idea simply to leave the spine in what Evian calls the actual resting position, and then do our technique down like that, or to do our technique down like that with the fingers, still using the resolution through the fingers and through the body. Another question in terms of whether we have the levers in extension or flexion. Certainly the longer the lever, if you're going to use it, I think it's better done in extension, particularly the upper lever. If I were not going to use the upper lever, however, I was using the impulse from the lower lever, I'd probably choose to place the upper lever in the flexion because it's less stressful for the patient. But if we need it rigid, then regardless of the congruency or non-congruency, and of course we're using the non-congruent lock in both flexion and extension, it's much easier to use the extension lever. And also, if we're using this, it's kind of hard. I can use you for a sec, Kelly. It's hard to just lay around there. That'll do. Leave it up on. Okay. If I've got Kelly, say, in a flexion lever like this, and I'm got her round a bit, and I'm trying to use this. It's not so easy to sort of apply my forces because I'm kind of falling off the body. Whereas if I come into extension and do this, she's right there in front of me, and this is easier to engage this lever. So if you want to protect, say we've got a hypermobile joint in this upper lever, I would use the non-congruent locking, but I'd put it in flexion because it's far more difficult for me to do an inadvertent stress against it in flexion rather than in extension. It's set up. It's just ready for me to kind of push at it in extension. But in flexion, it's not so much. So if I'm using it, I would have it in extension. If I want to use the lower lever, and all else being equal, I'd leave the upper lever in the flexion lever. And if I'd got a hypermobile joint in it, I certainly would, because I'd use a non-congruent locking, but I would sort of make sure that I had no difficulty with tending to push back as I kind of did this, because it's not set up really for taking any kind of stress. Now, let's just talk about one other thing, and thanks, I'll use Chris for this one. And I'll get you to lay round this way, Chris. And Kelly can make any notes if you... Yeah, facing this way. Head at that end. Face me, please.
Should I?
Yes, please. We've looked at rotation, and we've looked at distraction. What we haven't looked at is any of the other things, and we'd better do this because my colleagues use this quite frequently for the FRS lesions that won't go into extension, rotation, side flexion. All right? Come over towards me a little, and I use it too. What we should be thinking about here is how can we go into extension? If I'm going to use the bottom lever, perhaps I should put it into side flexion and extension and kind of lock it a little bit. And it's ideal to do this by having the leg here, taking this one back into extension to just below the joint I wish to move, lifting the table up now, making sure I don't go side bending up into it. Now I've got the spine in this position with the joint that I wish to gap, sort of waiting to have me push the lower lever forward and upwards a little bit, still producing a gapping on the upper side, because the gapping is a concomitant movement with rotation. And obviously if I push the pelvis this way, theoretically or by an anatomical description, I'm rotating him to the left. So for this technique we're going to sort of be careful. This is the one that Cassidy has the model of coming through the ischial tuberosity and doing that. And we wouldn't do this if there was any tendency to suspect an alteration in the diameter of the intervertebral foramen by a disc fragment or something like that. But if we got a patient who'd got a back that they kind of came back and they leaned over this way, and we sort of think, okay, go that way. But no, they can't get over to the left hand or to the left-hand side in this particular case. This might be a technique that would be suitable. And there are two ways of doing it. I can do it as a local side flexion extension, or I can do it as you have a description in the line diagrams of coming in. I'll have to go down a little bit lower. Of coming in here and just pushing forward like that. Now I don't like this technique particularly, this one. The one I prefer is the single-sided. But I think I may have to try this a little bit, because Cassidy sort of said that they had a lot of success with that technique in the group of patients that they had. So, you know, let's have a look at the article and bring it into part and see if it works for us. We're going to come down and across the iliac crest here like this, and my technique will be to keep my body close again, of course, because we don't want too much movement. Chris is already in the position of side bend rotation to the left side, and I'm just going to push down. Breathe out, Chris, and just breathe. There, and that movement, and I will get a little gapping as I go into extension. So that is the direction of my force. Just think about this on a bone. We've taken this up like this. My direction of force is going to be down like that, so you can see that the superior facet of the lower vertebra is coming up a bit into the intervertebral frame, and so I really don't want to do that if there's any loss of space there at all. But if there isn't, and we've just got this that won't go up, then I think to come into this and just push down here, and very often you can get very nice discrete little clicks in this joint by doing this. I doubt we will in anybody now here, because we've been kind of pushing at the back too much. Anybody sore? Little bit? Perhaps we should let you lay down and we'll place all that ice on your back. An ice back on your back. All right, so just try this very discreetly, and this will be the last technique we'll do in the lumbar spine for the time being. All right? Let's see where we go with that. Much as we should do on the lumbar spine this afternoon. You know, we've been sort of manipulating and so on, and I think we should be careful. Anne's a little sore, so she should be sitting in a chair with the back on, or laying down while I demonstrate the next thing. So we'll just stop a little bit now for a couple of minutes. And prior to stopping, we'll do like we did in the neck, which is a little bit of translatoric massage. So, I'm going to keep close to Alexei here, and I'm going to use my body, and I can use my body to give me side bend, and I can also use my arms and my body to give me rotation. So I'm simply going to pick up the muscles here, and there's a whole lot of movements that I can do with a rhythmic stretch on these muscles. Giving myself a little bit of movement, a little bit of side bend. Just moving around amongst the muscles here. Very kind of useful techniques, or in sort of straightforward side bend techniques. Using your body to get those movements, then add a little bit of rotation to them. Coming around a little bit, using my body so I can bring about a little bit of a flexion. You know, this is what you do, like Earl was telling me, sometimes he has to have his hot pack days. You know, when he just can't bear to sort of, we're working it all out and they're still not getting any better. Don't you realize how many courses and all this sort of stuff, and instead of getting angry, perhaps it's just that the weather's bad out there and there's a storm coming up, or there's electrical activity in the stratosphere, or something that's beyond our control. And certainly if half the people you're seeing this day are feeling sore, and you haven't seen them all on the same day because you were having a really bad day the last time all this group came in, then there's something out there going on, isn't there? You know, the Scirocco is arriving or something, where suicides go up and all this. So there is atmospheric things that make a big difference, as we all know. So some days, you know, we just can't go against the stream. So perhaps this is the kind of stuff. If you feel guilty about the hot pack days, then let's go into the soft tissue days. And then you think to yourself, there's masseurs out there that are charging $70-80 for a massage. Perhaps I'll do that. It'll be a lot easier. You know, on the side. So let's just do a little bit of sort of gentle translatoric movement in side bend. If we've got an odd one, I wouldn't mind a bit of this myself. Okay, so let's just see where we go with this on both sides, and then just change over. Just give your partner just a little bit of a break from all the pushing around. We'll pick up one or two techniques that we haven't done yet in the lumbar spine, but I think we've spent enough time, not in terms of the time, but in terms of the stresses that we've placed across everybody's spine now. So I think it's good to just let that relax. And so rather than going on and looking at some of the mobilizing techniques for hypermobility, or rather than going into looking at some of the higher techniques, sort of thoracolumbar area, we'll just give the lumbar spine a break for the time being. So now switch your minds, and those of you that have heard me talk in this area before have seen this sort of stuff that I feel in the cervicothoracic junction, how important it is. And we'll kind of go into some of the techniques in this area as far as manipulation. Now there's quite a lot of overflow from this area into the upper ribs, and also of course into the techniques for the upper thoracic spine below T4. So we're going to have kind of a good lot of techniques that we can then put into principle a little bit lower down. So it's going to be very helpful. Let's just think about that importance of the thoracolumbar, of the cervicothoracal area. Need to get, and we're talking about making a, a video, and I'm stumbling over words. The CT junction. Okay, this is a thing you've seen before from me, certainly, that when we're talking about flexion of the CT junction, we're really talking about also a chronic extension at the craniovertebral area. And so there's a very intimate relationship between this position and forward flexion at the CT junction. And so what does that relationship include? We're going to have extension at the craniovertebral complex with chronic shortening of the suboccipital muscles. The muscles that have the highest density of neuromuscular spindles anywhere in the body. So obviously this is going to have really pervasive effects throughout the whole body. If we take the thoraco-cervical junction into a flexed position, and if we take the craniovertebral area into an extended position, and then we have a look at the rotational movements of the neck, we see that the neck is not as mobile, because we've taken up some of the movement by going into the extremes of another movement, which is what Friot's third law stated. And this means that people that have got a repetitive movement to do, that are in this position, are straining themselves because they're taking it to the limit of their extensibility. If we look at the motion in the shoulder joints, this is very typical of patients that have these repetitive strain injuries, these accumulative stress injuries, whatever they're being called now, which is to come forward like this, and this rolls the shoulder girdle forward. If it rolls the shoulder girdle forward, we see that my total elevation is reduced. If I just correct my posture, I can get in another 15 degrees of movement, same shoulder joint. But if I'm forward like this and working above my head, this is going to have a very disastrous effect on the structures in the suprahumeral space. We change in the position of the shoulder girdle also alters the force couple of the supraspinatus, because it means that the glenoid is now looking not upwards and forward,